Dr. Abhishek Anand. Uh, he is presenting on a pilot study of suprachoroidal triamcinolone acetonide for macular edema due to non-infectious uveitis.
Hello everyone. Am I audible?
Yes.
Yes. Hold on a second. Thank you. So, I will be presenting a paper on pilot study of suprachoroidal triamcinolone acetonide for macular edema due to non-infectious posterior uveitis. My AIC number is A19473. I don't have any financial interest.
We're not able to see your slides. Can you share your slides, please?
Okay, just hold on a second. Sorry. Can you see my slides now?
Yes, yeah, full screen, please.
Yeah, I will do that. Is it fine now?
Yes, yeah.
So, good afternoon, everyone. I will be presenting a pilot study of suprachoroidal triamcinolone acetonide for macular edema due to non-infectious posterior uveitis. My AIC number is A19473, and I don't have any financial interest. We all know that uveitis account for approximately 5% to 20% cases of legal blindness in the developed world, and macular edema is one of the leading causes in it. And the mainstream of treatment for non-infectious posterior uveitis is corticosteroid therapy, that is the first line, and systemic being the one. But we all know that long track record of successful systemic steroid treatment for non-infectious uveitis is often marred by systemic side effects. And the question here is, can local steroid route achieve profound immunomodulation of target tissue without lenticular or angle associated or intravitreal injection associated risk factors? So we feel that suprachoroidal space can be a potential answer to it. The purpose of our study is to study the anatomical and functional outcome following a single low-dose suprachoroidal triamcinolone acetonide injection in non-infectious posterior uveitis. This was a prospective interventional study in a tertiary eye care center in East India. It adhered to the declaration of Helsinki, and it was passed by the institutional ethics committee. We took around 11 eyes of 11 patients, and we offered rescue therapy was offered if patients were not responding to the treatment or worsening of the disease activity was noted. And statistical analysis was done by using SPSS software. The primary objective was to look for how the treatment success was defined as greater than 10% reduction in CMT from baseline maintained throughout 4 to 12 weeks. And our secondary objectives, we also examined the best changes in the best corrected visual activity, as well as effect on other inflammatory parameters like vitreous haze, perivascular searing, duration, or changes in the choroiditis nodules or granuloma. We also, in addition, examined how many percentage of subjects were able to achieve greater than 20% and greater than 50% reduction in CMT at 4 and 12 weeks. These are our inclusion criteria, and these are our exclusion criteria, mainly being that the patient should not have any history of steroid treatment for last 3 months and any interest history of intravitreal injection for last 6 months, or any history of patient being at risk for developing glaucoma. These are the study parameters which we examined, mainly being demographic data, BCVA, IOP, and certain examination, and OCT and fundus fluorescein. We did the 3 complete set of examination, one before injection at 4 weeks and 12 weeks post injection. All subjects received a single unilateral suprachoroidal injection through a specialized needle made by Tricon MIC, and approximately 4 millimeter from the limbus. 2 milligram was used. We had 4 patients of intermediate uveitis or vasculititis. We have 3 patients of vasculitis with CME, 2 patients of choroiditis and choroidal granuloma, and 2 patients of VKS syndrome. If you look at the change in the CMT, the top line is the pre-intervention, which is the blue line, and we can say that there is significant change at 4 weeks and 4 weeks, 2 and 12 weeks, and it was statistically significant less than 0. Out of the 10 eyes, 9 eyes in the treatment success subtotal group had greater than 20% reduction, and greater than 50 reduction was achieved in 3 and 4 eyes at 4 and 12 weeks. The 11 eye was not included because the patient was a case of VKH, and once we injected, the patient developed an exudative detachment, so the OCT was not picking up, so we were not able to know what data we should use. And that was also the treatment failure, and the patient was put on systemic rescue therapy. The changes in the CMT corroborated with the changes in the BCVA, and both 4 weeks and 12 weeks, the gain in the vision was statistically significant. And these are what is important. We also wanted to emphasize in our study is that it just not only affects the macular edema, but it has a profound effect in overall inflammatory parameters like vitritis, vasculitis, perivascular sealing, or changes in the choroiditis or choroidal granuloma. And so And regarding the adverse events, there was one case which was had a slight rise in the IOP and was put on a single anti-glaucoma medication. Other were minor side effects which are associated. Now look, this is a patient of vasculitis. On the right side of the image, we can, in the color fundus photograph, we see a lot of perivascular seeding, and this patient only received a single dose of 2 milligrams suprachoroidal. We can see that all the vascularity is well controlled and the perivascular agitation has resolved by 12 weeks, and the foveal contour is established and at 12 weeks. This is another case of VKH, and we can see that the choroidal infiltration have been choroidal infiltration of the inflammatory cells have almost resolved, and the patient is completely maintained at 12 weeks and with complete restoration of the foveal contour. This is another patient of choroiditis who presented with CME, and we can see that at 12 weeks, the choroidal active choroiditis has subsided and has now changed into a quiescent scar, and the foveal contour is maintained at 12 weeks. So, what we can say is the suprachoroidal space ensures high viability of these small molecules like TA in comparison to the intravitreal or posterior, as proven by different authors in the past. And TA and supra also acts as a depot, and levels are maintained in retina, choroid, and vitreous. In fact, we feel that it is more than 90 days. And dose sparing can be used to achieve similar efficacy via CS compared with traditional route of administration. There have been two past studies, the Bogwood study and the Peachtree study, and our dosing of 2 milligram achieved comparable or even better reduction in CMT in comparison to the 4 milligram. The BCVA was also comparable. What we want to hypothesize that likely low dose suprachoroidal steroid has profound effects on disease activity in non-infectious uveitis, and it can be the first line and sole therapy in patients with posterior uveitis in controlling inflammation and reduction of CMT. The novelty of the study is a 2 milligram low dose steroid and the new design suprachoroidal medium by Pricon Surgicals. However, a small sample size is the limitation of this study. These are my references. Thank you.
It's an interesting study. I also want to know, did you do any ERG changes in yours? And because your period of follow-up is very short, right? 3 months. It would have been nice if you had a comparison in terms of that.
Actually, we have few patients in this study only, which have now 1.5 years. At my regional institute of ophthalmology, we don't have an access to ERG, so I am not be able to perform ERG in my patient. However, certainly your suggestion would have been very handy if we had an access to ERG. Certainly, we would like to have performed ERG. But if we compare the different papers published in IOBS on suprachoroidal triamcinolone acetonide, they have compared the ERG and they have said there is no changes in the ERG in experimental models.
Because the 3-month duration which you have taken, an intravitreal steroid would work as well, the same thing, especially if you're looking at efficacy.
But
so it would have been nice if there was a
it's just like we have not put the data, but now of these 11 eyes, we have data of around 3 eyes who are now following us for 2 years. And now because of the lockdown, we could not increase the number of the patients. And the most important is that most of the patients that come to us, they are not treatment naive. Most of them have started steroid or some other form of treatment. So it's also hard to recruit the patient. But 3 eyes have now 2-year follow-up. One was with choroiditis and another with VKH, and they are maintaining a quiescent stage without any recurrence or anything.
Thank you.
What is the maximum number of injections that you've given?
Ma'am, in most of the patients, out of the 11 eyes, I gave only 1 single injection and they have maintained the quiescence. Okay. But when I have used suprachoroidal in diabetic macular edema, I had to repeat injections, but not in uveitis.
Excuse me. What are the grievous local side effects? Did you fail any in your 11 cases?
So the most important side effect that we, when we are administering drug, is that we are scared that whether we will be inadvertently injecting in the intravitreal route. But this is a learning curve that we have. Otherwise, what is the new design by the Pricon Surgicals, what we do is that when you inject, you feel a giveaway. When you enter the sclera, you'll feel there is a giveaway, and then there is a loss of resistance, and then we are easily able to inject it. In none of the eyes, I had inadvertent injections in the intravitreal route. The one major thing difference between intravitreal injection and a suprachoroidal injection, the patient will complain of pain post-injection. That is most probably due to the stretching of the choroidal suprachoroidal nerves in the suprachoroidal space. So they do complain of significant phase at least for 4 to 5 hours, and then it subsides.